that's also a useful resource to flag as well. So we're going to go to the didactic presentation. This part of the presentation is going to be recorded, so you can get hold of the recording at a later date. And Shilpa, do you want to share your slides?
Okay, I will. All right, so how does that look at your end, guys?
That's good.
Perfect, excellent. So do you want me to just kick off, Stephanie?
Yeah, you go for it. And then at the end, we'll ask some questions.
Okay, fantastic. So thank you, everyone. Today we're going to be focusing on early detection of chronic kidney disease, and then there's a whole bunch of other modules that are coming after tonight that are going to take you through aspects of management, etc. So I am, there we go. So a lot of what I'll be presenting, there are some slides that are mine, but most of what I'm presenting really comes from Kidney Health Australia. There's really no need to look anywhere else if you're looking for health professional resources around CKD, and I'm presuming you're all familiar with the CKD Management in Primary Care Handbook. We've just launched the 5th edition. In fact, I was delighted to have that launched in my renal unit at the Royal Adelaide earlier this year. And the CKD Go app that accompanies the handbook has also been updated. If you don't have this app, please have a look at it. It's actually really swish, this version. It's a real delight to, as much as any sort of medical app can be a delight, it is a delight to use. And what I love to do with it is actually, use the CKD calculator and use it to show my patients where they're sitting and give them some visuals and language to go along with their CKD diagnosis. So get the handbook off the website, get the app, and then you will be good to go. We've got some learning objectives and outcomes here. So really, if you didn't already know that chronic kidney disease is critically important, hopefully we really send that message home today. I'm going to take you through how to do a kidney health check and really embed that in your practice, and then just give you some broad principles of management approaches for delaying progression of kidney disease. But as I said, the really detailed management stuff is going to come in the subsequent apnea echo modules. And so today's just a taster, and so don't forget to come back in future for the more detailed management stuff. I always like to start with a definition, and we talk a lot about chronic kidney disease, but it can be defined in 2 ways. The first is if we just look at the estimated GFR. So an estimated GFR of less than 60 mils per minute that's there for more than 3 months, i.e. the chronic bit, is enough to say this person has chronic kidney disease. However, we all know you can have normal GFR and still have other evidence of renal damage, either with albuminuria, proteinuria, hematuria, structural abnormalities. So, for example, if you do kidney imaging and the patient's got rampant polycystic kidney disease, or if a renal biopsy is done and there's clearly evidence of renal pathology, that's also chronic kidney disease, but it may not be with reduced GFR. Now, we talk a lot about GFR, and I like to show, this is not a Kidney Health Australia slide, but I like to just throw it in just to show you what the G part of GFR looks like. So, we've got 2 kidneys by and large. Each kidney usually has around 1 million nephrons, and the nephron starts with the glomerulus. And this is what the glomerulus is. It's a very large, sac of capillaries, and the purpose of these capillaries is to provide a very large surface area for filtration. So that's, when we're talking about GFR, we need to think about the glomerulus and the filtration that occurs, the filtration of blood that occurs in that glomerulus. And this is an electron microscopy picture of what that glomerulus looks like. Now, as I said, you've got about 1 million of these in each kidney. Some people have less. What you're born with is what you have for life. If you're born early, low birth weight, or if your parents had chronic kidney disease, you're actually born with fewer nephrons, and you've got no ability in your life to increase your nephron endowment. So the amount of G or out of GFR that you're born with is pretty much, that's the best that it's going to get for you in life. So we've got to protect these glomeruli. Now, if you take that glomerulus that I've just shown you and you cut it in cross-section, what you can see here is a cross-section of all of the capillary loops. And you can see that by and large, they look nice and open. And they look like, that's the big white spaces. I always get very nervous when I'm showing renal histopathology to people not used to looking at it. But I think that, you can see that cut in cross-section, those capillary loops are cut in half, nice wide white spaces where blood can flow, and then that filtration can occur. So keep that picture in mind. That's a normal glomerulus. Now I'm going to show you my world. So this is what advanced diabetic kidney disease looks like. So if there's only two things that you go away with in your mind, because a picture tells 1,000 words, you can see the difference between that and that. So everything that I tell you from here on in is all about keeping people here, even though they've got risk factors for chronic kidney disease, and stopping them from getting to this point, okay? Now, by the time the patient is at this point, I'm sorry to say no amount of controlling their hemoglobin A1C or putting them on RAS blockade is actually going to fix this problem. This person, if all of their glomeruli look like this, they're well on their way to me and to being a permanent member of my dialysis unit, okay? So we are trying to stop this sort of glomerular lesion and renal damage developing, and I'll give you the example of diabetes, but of course we see many kidney conditions, but diabetes is the main one. So here's some facts, and those of you who've been listening to Kidney Health Australia webinars for long enough should be able to recite this with me by now, okay? So we can have a bit of a sing-along. So 1 in 10 adult Australians are, if you go looking for evidence of chronic kidney disease, biomedical markers, they will have reduced kidney function or albuminuria. 1 in 10 adult Australians, okay? CKD is actually twice as common as diabetes if you go looking for it. And then 1 in 3 adult Australians actually have at least one have got risk factors that will increase their risk of chronic kidney disease. So this is a really common problem, and these are the patients that are sitting in your practices in primary care. But if you then take those people who've got biomedical markers of chronic kidney disease, and if you ask them, do you have kidney disease, less than 10% of them are going to identify as having chronic kidney disease, and it's because we have not told them, we have not given them a language with which to talk about this. To compound that, you can lose up to 90% of kidney function without having symptoms. And, every week in my renal unit, I have people walk in off the street, never felt sick until the last couple of weeks, and get told they need to permanently be put on dialysis. And they have completely missed the boat in terms of the earlier stages of CKD and are at CKD stage 5. It's really confronting for them and very difficult for us to manage. And we know that those sorts of late referrals for chronic kidney disease are really quite bad. We've made a bit of a dent in that number over the last couple of decades, particularly since EGFR reporting. But we know that, still in this current day and age, about 17% of people start dialysis within 3 months of being referred to a renal service, which means that they've had no chance for planning. They've had no chance for preparation. It is a completely shock diagnosis, and we call them crash landers. And that's something that we really need to work hard to turn around, because a lot of those people should have been picked up earlier than what they were. So this is the pyramid of kidney disease that we're seeing in this country. At the very tip are the people in my clinical practice, those on dialysis, transplant, or stage 4-5 CKD. But what I really want you to focus on is all of those people further down the pyramid, that 5 million plus people at risk of chronic kidney disease, and then those people with earlier stages of kidney disease. And this is the other visual that I want you to take home, is we want to stop people from climbing that pyramid, okay? Our early detection strategies, our prevention of progression strategies are all about stopping people from climbing that pyramid. of course, there's a very important part of that pyramid that's not there, and that's the people with advanced kidney failure who don't end up having kidney replacement therapy with dialysis or transplant and end up dying through palliative care or supportive care with renal failure, but a non-dialysis pathway. And we don't capture those particularly well at the moment, but they are definitely around. So this is a really big burden of disease or risk of disease. We know that a lot of Australians die with chronic kidney disease. Okay, a lot of people die from chronic kidney disease, but they also die from cardiovascular disease. And you'll hear us over the course of these modules talking a lot about the link between CKD and cardiovascular disease. We also know that that this is a problem that is very burdensome in the worst socioeconomic and demographic cohorts who are least equipped to deal with this additional chronic disease burden. We know that if you start in the centre with this, triple whammy of diabetes, cardiovascular disease, chronic kidney disease, one layer of the onion is all of the biomedical issues. The next layer is the physical and cognitive and symptom impact. And then the final layer is the social, financial, and family and community impact. So this is really the onion and the ripple effect of chronic kidney disease. When we look at causes of chronic kidney disease, when I started my career as a nephrologist, it was IgA nephropathy at the top there. In the time that I've been practicing, diabetes has taken over. And this is a really huge problem. And so then you've got diabetes, you've got glomerular disease, hypertension, and then all of the other genetic and other conditions. That's commonly what we see in Australia. When we look at causes of kidney failure, you can see that diabetes definitely wins, but particularly in Aboriginal and Torres Strait Islander people, diabetes is a huge problem. And then you've got hypertension and then a whole bunch of other causes and glomerular disease as well, okay? But this is why we really want to focus on some of the early detection stuff, because the predominant causes of kidney failure are chronic. They're coming for a long time. Sure, we all get the patient, the odd patient who walks in with, vasculitis that just developed or lupus that just developed very quickly and suddenly. But by and large, these are chronic conditions leading to kidney failure. So ample opportunity for early detection. So hypertension, a classic example. The relationship with kidney disease and hypertension is bidirectional. Each causes the other, but plenty of time to pick this up, manage this well, and prevent progression. So I guess that lead-in time is really what I want to point out to you. We know these overlaps exist with CKD, cardiovascular disease, and diabetes, and that's that base of the pyramid. 5.6 million Australians have at least one of these three conditions, so it's pretty common. And then, of course, if you're adding in diabetes and CKD together, you're increasing your cardiovascular risk, and you're basically making, having diabetes makes all of the outcomes of the CKD worse at every single CKD stage. And 1 in 3 people with diabetes will eventually develop CKD. Again, something that we can turn around with the right management, and we have the tools to do this. Okay, I'm going to keep moving on. This is what's happened to dialysis in Australia. This is why I don't fear that I'm going to ever be out of a job. I would love to see this graph being turned around, and I hope that with the new therapies we've got coming through, we will actually, in my time and my career, see this turning around. But this is largely because we're accepting more people onto dialysis, but it is a tsunami of patients requiring dialysis in this country. And if you look at the cause, here is the red line, the diabetes going up. Again, hasn't happened overnight. Takes years for diabetic kidney disease to develop, plenty of time to turn it around. So I guess the other key message that I want to get home to you is that this is a treatable condition. Okay, we can reduce deterioration in kidney function in up to 50% of people, and we can slow the progression of chronic kidney disease by up to 15 years if we actually start patients earlier with the right treatment. So we've we've got to use the strategies that we have for early detection to stage CKD, to find it, stage it, put in the right treatment, and then reduce the risk of progressive kidney failure, the risk of cardiovascular disease, and the risk of morbidity and mortality. So this opportunity basically sits in all of our hands. It sits with you guys. You know, we really mustn't be missing this opportunity. Luckily, the kidney health check is pretty straightforward. Blood pressure test, GFR, urine. Okay, I'll talk a little bit more about the urine in a moment, but this is actually straightforward. It's not pooing into a plastic bag. It's, like colorectal cancer screening. It's not having a colonoscopy. It's not, some of the other screening tests that we do. This is fairly straightforward, can easily be done in the community with tests that are widely and readily available. Who should be offered a kidney health check? Well, people who are at risk of chronic kidney disease. So there's all the classic, I've already talked about diabetes, hypertension, established cardiovascular disease, etc., obesity. The ones that you might not think about are, always think about family history. If they've had an acute kidney injury in the past, you're more at risk, okay? And with the hypertension, we mustn't forget that having hypertension in a pregnancy in the past is an important part of the history. So, hypertension at any stage. And so for women, you should be asking about the pregnancy history. So these are the typical risk factors, and these people should be followed up. So this is what we would recommend for non-Indigenous Australians, that depending on what your indications are for assessment, either an annual or biannual kidney health check, definitely after an acute kidney injury episode, and then, also as patients are getting older. And then, this is something that needs to be repeated on a regular basis as the situation changes. For First Nations Australians, slightly different. The risk of chronic kidney disease is so high that really you've got to be convincing yourself not to do a kidney health check rather than finding reasons why to do one, okay? And we hear a lot from First Nations Australians that they are very interested in early detection to turn around the burden of chronic kidney disease in their community. And so this is how you do it. You offer your kidney health check, you do your ACR and eGFR, and there's an algorithm in the handbook, which I'm not going to go through, about what you should do next. And it's really very straightforward. It's about just repeating the measures and making sure that that you've got true results, and then saying, yep, okay, this person does have chronic kidney disease, biomedical features, and I'm going to go on and do the CKD staging. Now, you do this by, once you've confirmed that there's albuminuria, once you've confirmed the GFR is reduced, you can plug it into this sort of algorithm, and this heat map basically tells you the risk that this patient is going to end up with either kidney failure down the track or a cardiovascular event. It goes for both. So people who are in the green don't have CKD unless you've got other evidence. The yellow, the orange, the red are progressive stages of risk, and they link very nicely to the clinical action plans in the KHA management handbook. Okay, so all of this is in the handbook, and it really does take you step by step through this staging of CKD. Now, we've got, we're looking at GFR. We know that that's the best measure of kidney function. You've got your picture in your head now of what the glomerulus looks like. We use the creatinine, and it's automatically reported on all of your pathology. And these are the different criteria of GFR. So that's pretty straightforward. Interpreting the GFR results, you need to just understand the limitations of it. And so you can't really use it in pregnant women. You can't use it if their kidney function is rapidly changing. You can't use it at extremes of age or body size. But by and large, it's a good guide to what the renal function is actually doing. Urine ACR is an important marker of kidney damage, and when the urine ACR is high, your cardiovascular risk and your kidney failure risk goes up. If you lower it through medications, you reduce the risk of kidney failure and cardiovascular disease. And it's actually a really, really important sign. It's often missed. We see so many people who get referred in have never had a urine ACR before. We've done lots of research looking at, biomedical markers of chronic kidney disease, people will have reduced GFR, but no one has done the ACR. So critically important. How do we detect albuminuria? Now, a lot of people get hung up on this, and my view is very pragmatic. I don't really care when you do it, how you do it, what time you do it, just do it. It is so important to at least start looking for albuminuria. Technically, we say it should be on the first void sample, etc., because of the circadian rhythm of protein excretion, but actually a random sample is just fine. We don't generally use dipsticks because you can miss important proteinuria or albuminuria. So it's very good for, if you've got nephrotic syndrome and you're hosing out protein, sure, a dipstick's going to pick that up. But for earlier stages, it's not reassuring just to have a negative dipstick. You will miss cases, okay? It is very rare to need a 24-hour urine collection. I see a lot of GPs doing this. It is not necessary. Even in my practice, I rarely do 24-hour urine collection. The ACR is helpful, and that's fine. That's usually enough. Urine ACR can be affected by a whole bunch of different things, which is why we get you to do it a couple of times if it's positive, okay? But even just having bad heart failure, even exercising heavily, having a urinary tract infection, all of these things can affect the ACR. That's why you need the confirmatory test. So this is fairly straightforward now. GFR, urine ACR, try and look for the underlying cause of the chronic kidney disease, and then you have your CKD diagnosis, okay? We need to see it over 3 months, these consistent abnormalities over a 3-month period. And then it's, a few simple things to go into looking at why there's evidence of chronic kidney disease. Okay, so I just wanted to mention again these colour-coded action plans. So, just say you've staged someone in the orange zone here. They've got stage 3A level of GFR and they've got microalbuminuria, then they're going to be in the orange clinical action plan. And this takes you step by step, takes the yellow action plan actions and adds in what's needed when you're at the orange stage. We have tried really hard in these action plans to be very pragmatic. What can be reasonably achieved in a primary care setting? Not getting too fancy pants or highfalutin about what needs to be done. This is basic investigations and general guidelines. Of course, once you're starting to get into the red, nephrology referral may become part of that. Why is it so important to do that, everything that I've just talked about? Because, as I said, we know that we can turn this around. Today is not about talking about management, but I couldn't let you go without just touching on the key management strategies for chronic kidney disease. The goals are to slow down that decline in GFR, reduce the albuminuria, get blood pressure to target. We know there's a lot of blood pressure inertia that happens in Australia. We want to lower cardiovascular risk. And so the current pillars of chronic kidney disease care right now in 2024 are obviously all the lifestyle measures, smoking, nutrition, physical activity, etc. Blood pressure control to a target of less than 130/80. Renin-angiotensin blockade with ACE inhibitors or ARB and pushing them to the maximum tolerated dose. An SGLT2 inhibitor, which significantly slows down CKD progression, plus or minus mineralocorticoid receptor antagonist and GLP-1 antagonist. The evidence for that is definitely coming through. And then other strategies to address cardiovascular risk, including lipid management and smoking cessation. So that is basically what, I'm now seeing patients in clinic with sent to nephrology to slow down chronic kidney disease. This is what I'm going through and making sure that all of these, if possible, are in place to help turn that around. In your practice, you'll really need a whole of practice approach. It takes everybody together with all the tools available around our electronic medical records, e-health, utilising the MBS item numbers, bringing in your practice nurses, coding CKD correctly in your software. it's a whole of practice approach to trying to turn around chronic kidney disease. So there's a lot more that I could say. Kidney Health Australia has heaps of resources, both for health professionals and patients. Join the Kidney Health Professional Hub. There's a host of information there for you. And please keep coming to our webinars so that you can get further information. There's a lot more to come with these echo modules around management. A few years ago, I initiated some CKD management information in health pathways, and I'm delighted to hear that that will be progressing. Our website for the Royal Adelaide Renal Unit is up on the Carlin website, and we've got a lot of info there. And I've just been working with the on some statewide referral guidelines for sending patients to renal clinic, which are not really about triaging patients, but about giving you guys the support that you need to work out what's important, what should be prioritised. So happy to stop there and have this panel discussion and take any questions. So back to you,